sit down.
Yeah, it is rather hot, isn't it? It was a bit noisy outside, so I closed the doors, but we could try opening the doors and it's not too noisy and just leave it on. Okay. John, thank you very much for coming. Now, we talked about the relationship between the service side and the academic side. So, John is from the academic side. He's here at Southampton University, working in ethics, with especially around public health, and how ethics applies to that. And he's going to talk about some of the work that he and his department's been doing to give you a flavour of another aspect of global health.
Thank you, John. Thank you, everyone, for being here in part to listen to what I have to say. I'm based in the School of Law here in the university, and two of my other law colleagues are here, Adrian with the fetching beard and Claire beside him. We work both in kind of hard law, looking at practical legal issues. Claire's PhD thesis, which is almost complete, is on the human right to health. Adrian's background is philosophy, and I have a kind of mixed background. So I began by studying law. My PhD was supervised by a philosopher, and we're very interested in how one conceptualizes different imperatives that would then feed in, as people would hope, into how we govern questions concerning health. So very much, of course, we're from the university side, but we're also then from the humanities side. So at first blush, we may appear not to bring much by way of sort of real-world application. I hope to explain the sorts of questions that we engage with in public health ethics, public health law, and then also look to how these can feed into practical activity. So the bulk of my talk is the top bit, substantive questions around the fields, first of all, of public health ethics and law, which is where my expertise really lies, and then how these feed into questions concerning global health. I then have just a couple of slides respectively on introducing the wider group with whom I work in the law school, and there's quite a lot of us involved in health-related activity, and I'd be very pleased if this could serve to maybe fix people up with that, and also just refer to a couple of particular activities that we've engaged in to demonstrate that it's, I hope, not just sort of ivory tower navel gazing about human flourishing and things like that. Okay. So, first of all, what are public health ethics and public health law supposed to mean? These two characterizations are drawn from a book I wrote a few years ago now. I became very interested, like a lot of humanities scholars did, maybe around 2005 or so, in questions concerning public health. So bioethics, examination of sort of philosophical questions around healthcare, seem to be very much dominated by very individual problems, so the rights or wrongs of abortion or euthanasia and so forth. And people got increasingly interested in public health institutions and how we ought to understand responsibility for health within a society, as opposed to just focusing on the individual. So, having studied these things, I characterise public health law as referring to those aspects of law, policy and regulation that bear on the health status, however we take ourselves to understand that, of their subjects. So, having analysed the works that are developing in public health law, we have a very broad concept there. We're not just interested in hard regulation, we're interested in policy as well, and we're not just interested in a narrowly limited jurisdiction, so we're not just looking at the work of Public Health England or the work of the Department of Health. We're interested in work across government. Public health ethics, I posit as the critical ethical evaluation of questions concerning possible, actual and proposed public health measures. So for me, public health ethics is about the examination of the imperatives that we see in health. It's not saying health is good, therefore. It's asking why we care about health, why we care about other things, and how we balance the competing values and principles. Okay, and I think if we get that deeper understanding of these sorts of questions, that I hope the work such as that which I and my colleagues undertake, I hope if we get that understanding, then it will advance the agendas that everyone in this room is interested by. I would flag up, not for publicity purposes, but the title of my work is What Makes Health Public? And within a public health context, I think that's the fundamental question. So I think anyone who's engaging in public health ethics is asking that question. So not why should you care about your health, but why should you care about my health, and how do we bring that together through political institutions? Why do we make other people's health or health-affecting behaviours the business of others? If you're asking those questions, you're asking what makes health public. When you derive an answer, a reasoned answer to that, you're doing public health ethics. Right, quite a long introduction, but there we go. So here is the canonical definition of public health taken from Winslow's work. I think many people in the room will be familiar with this. So public health, again, just thinking at a national level, is the science and art of preventing disease, prolonging life, and promoting physical health and efficiency through organised community efforts. And we see Winslow lists various things that take us well beyond just healthcare. So we're interested in social determinants of health, we're interested in a wider public health infrastructure. And this definition has been very influential. Some of you may be familiar with Solly Benatar and Ross Upshur's characterisation of global health. And you can see very clearly how this derives from Winslow's definition, but we can also notice some subtle differences. Some of them because of more updated concerns for different health-related issues, but also because the coordination is going to be much harder. So if we compare those definitions, we see similarities, but also differences. And those differences, I think, are perfectly encapsulated in this quotation from an academic lawyer from the United States, David Fidler. I'm going to read this out. He says, "The hard question is not whether law is practically or philosophically important to public health, but whether the political conditions in which the body of public health law and its supporting philosophy must operate are conducive to governance progress in the protection of population health." So for Winslow, he talks about organised community efforts. Now, at a national level, within a nation, at local levels, we can find plenty of obvious political mechanisms for controlling behaviour. At a global level, that coordination is much harder, and so the challenge for people such as me who would wish to work in global health is looking at how we get that coordination implemented. I think the most influential scholar in this field is Larry Gostin from Georgetown University in the United States. And in his recently published tome, Global Health Law, he actually advances an important concept, not just in the idea of global health law, but more accurately in governance for global health. Okay, so first of all, he tells us what governance means. It's the method by which organised society directs, influences and coordinates public and private activities to achieve collective goods. It includes not only law, but also multiple levers to effect change. Gostin emphasises that because from an international lawyer's perspective, and I should be clear, I'm not an international lawyer, unlike my esteemed colleague, but from an international law perspective, we have real difficulties understanding how we coordinate activity. We haven't got the same sort of central institutions that we have at a state level. We don't have the same mechanisms for enforcing obligations, even where big actors have assumed them. We also have huge actors that fall outside of the commonly understood international framework. Fidler says regulating Bill Gates is going to be very different than regulating the United States, and on the international stage regulating either isn't going to be terribly fun, right? Or terribly easy. So we need to work out how we do that. Moving back round to questions of ethics, I want to conclude this slide in relation to Gostin before contrasting with another scholar from the States. But Gostin looks for the best means possible of coordinating activity whilst accepting that we're not going to do this perfectly, and we're going to do it far from perfectly. So he doesn't advance a utopian ideal at all. Well, some people will say he still does, but it seems rather modest compared to some of the things that we see going on. But what I want to highlight is that Gostin in his work, and he's been as much an activist as he's been a scholar throughout his career, Gostin in his work does believe that health is of fundamental importance. So he builds a whole social theory on the fundamental capabilities that are rooted in people having good health. But when he's applying that in the context of global health, and his domestic work is in the United States, so it's exactly the same in his work on public health, because everyone there seems to fear the government. he looks for the complexity of the undertaking, navigating the cross-currents of politics, power and vested interest. So as we develop our governance mechanisms, as we develop our understanding of how we ought to control behaviour of institutions, of individuals, we need to play to the different interests. We have to account for the different power dynamics. And it's a much more complicated task than in national public health law. Very briefly, I wish to contrast this with work that's been published by Jennifer Ruger. Like Gostin, Ruger publishes in journals that we, I presume, have fairly easy access to in terms of actually sort of being entitled to look at them, but she also writes very accessibly, so you can look at this. And I think it's interesting to go away and reflect on, so I encourage you to read this paper, to go and reflect on Ruger's arguments. So like Gostin, she recognises that there's a multiplicity of actors. She refers to hyperpluralism and fragmentation. By that she means there's an awful lot of different agendas going on, there's an awful lot of different institutional and individual actors at play. And the fragmentation means they're not coordinating their activity. And of course sometimes this can, even when it's benign, it can lead to more harm than good. So you end up having bits of medical equipment collecting dust because they're useless and things like that. Okay, we have anarchic conditions. There's no central coordinator and there are distinct goals. Gostin seems to wish to change this. He's been a long advocate for a framework convention on global health, but he seems to see that no, power games are what they are and we have to live with that. We're not going to be able to govern these things perfectly. Ruger, by contrast, advances a theory of global health justice, which she suggests we ought to be advocating for, and on the back of it, developing global health institutions. So she argues for a global health constitution that would overarch the WHO, and a global health body that would regulate actors including the WHO. So we'd have a clear list of whose responsibilities were what, and would have some means of adjudicating if there were uncertainty about how the rules ought to be applied. So I just leave that there because we've got two, I think, quite different approaches. In the final minute, I'm just going to do a bit of, I guess, this is sort of self-publicity or something like that, but it's in the spirit of the occasion. So, expanding networks. The overall research centre that I work on, I'm going to speak to in a second, but Adrian and I set up the Public Health Ethics and Law group, which is eminently Googleable, and we welcome contact from people who are interested in trying to feed on our expertise, and we have various collaborative activities ongoing in teaching, in research, and in relation to practice. But it's a wider group than that. So in a law school of, I think, about 45 members of full-time staff, we've got 8 people working on law and health. Okay, and the slide here indicates the range of interest from reproductive health, medical research, public health, global health, and so on. We've got a whole range of activities, and we've got the 2 URLs here. HEAL, the Health Ethics and Law Centre, is the overarching centre that we work within, and then, as I say, we've got the Public Health Ethics and Law group within that. So if you are interested in perhaps feeding off our expertise, then I encourage you to look to that. And I promise that I would suggest that we really do stuff that has some sort of impact on the world. I thought in the context of today, because this has been applied in relation to Ebola, it would be a good idea to highlight Adrian's involvement in the development of this guidance from the World Health Organization. The chapter that Adrian contributed to, that Adrian helped develop, relates to the development of ethical guidance, where he speaks both to procedural values and substantive values. The guidance wasn't a response to Ebola, although it's applicable there, but it's applicable more generally in public health crises, and that builds directly upon Adrian's work on pandemic planning. Different sorts of activities. We are pleased to be involved in the delivery of CPD teaching in relation to public health, as well as our university teaching, and also we're involved in an application process at the moment with Nirvani, which, if it's successful, will bring ethics capacity to global health teaching in West Africa, which would be fantastic. So that's the sort of range of things we're doing. It starts from very big picture theorising and conceptualisation, but aims to do so to make more robust the ethical claims that are then made in support of proposals for advances in policy and practice. So that's what the lawyers bring. We're nice lawyers, we're not practicing.